Hello, thank you, Dr. Vargas, for the invitation. I am Hernán Martinez Osorio from Barranquilla Hospital, UAE. I will talk about the Boston Keratoprosthesis in the King Khaled Eye Specialist Hospital. It's a new clinic that we create in 2019. We create this clinic because we were dealing with a lot of complications, mainly extrusion, infection, also retinal glaucoma complication, erythroprosthetic membrane, and we always treat this patient with a multidisciplinary team. We deal with a lot of complications about extrusion and infection. Recently, we published this article about the outcome of the Boston Keratoprosthesis in the King Khaled Eye Specialist Hospital. We divide the patient for the analysis into groups. One group, the patient never did glaucoma surgery at the same before or during the K-pro implantation. This patient had the diagnosis mainly of Steven Johnson, chemical injury, mucus pemphigoid, and the other group was a group what it was the diagnosis was bullous keratopathy or infection keratitis. This patient had more glaucoma than the other, as was expected, but this patient, the glaucoma surgery was done immediately before the surgery or during the K-pro implantation. As was expected in the group 1, the patient with the inflammatory condition, they have more endophthalmitis, macular keratitis, and finishing K-pro removal and evisceration instead of the other group that they have more retinal and glaucoma complication. The functional and anatomical outcomes was unfortunately the SEDOT International Series. We are expecting to treat around 22 new cases of severe ocular form every 2 years, 44 new cases of pemphigoid, and adjusting the mortality in the articles published before, there was around 60,000 patients and more than 8,000 patients with trachoma corneal scars in the kingdom. The first step was to create the guidelines, and this is the K-pro news when we created the K-pro clinic in 2009. Initially, the indication, we were not willing to do patients with the primary keratoprosthesis surgery, and contraindication was severe dryness, ocular surface keratinization, and severe eyelid dysfunction. This patient, we offered tibial bone keratoprosthesis. We did only one. The other 6 patients rejected the surgery because of the cosmetic issues. Regarding the preoperative evaluation, it's a normal preoperative evaluation, but we always send the patient to the glaucoma specialist. It was really important because we have a lot of problems with the glaucoma. And after the postoperative evaluation after the surgery, also anterior segment OCT, visual field anterior segment OCT every 3 months, at least every 3 months, plus the normal follow-up. Regarding the selection of the prophylactic antibiotic, we select vancomycin and Vigamox, and every visit we put povidone in these patients, and also every 3 months we replace the soft contact lens. Regarding the follow-up, the patient after the 2nd month had to attend at least 1 appointment every 3 months in the K-pro clinic. We did 30 surgeries during the first 2 years of creation of the K-pro clinic. There was 2 surgeons that one was part of the K-pro clinic, or they still were doing surgeries. Only 1 patient was pediatric patient and 1 patient older than 90 years old. Most of them were males. We did surgeries in 50% of the patient, 1 eye patient, and 2 patients operated outside the K-pro clinic. The fellow eye division was normal. The indication, mainly the patient was a regraph, and also we have patients with replacement and primary K-pro. Regarding the regraph, I am highlighting the emerging indication as congenital glaucoma, aniridia, cerebral pigmentosa, and in the opposite that I was expecting, we did only 2 patients, 1 with trachoma, 1 with chemical burn. The other patient was bullous keratopathy, was expected. Regarding the primary, also the emerging indication, aniridia we highlight, and regarding the replacement that was expected, the eldest patient with OCP and trachoma. We also create 3 quality management indicators in order to analyze the outcome of the K-pro clinic. The first one was the glaucoma surgery. I will tell you what 100% of the patients were operated with the glaucoma at the same time of the implantation. We did it only in 71%, most of them with the UCP. Dr. Vargas will explain in his talk about the surgery. The patient with pre-existing glaucoma before the surgery, in all of them with the surgery, and the patient that they didn't have, in half of them only we did the glaucoma surgery. Regarding the improvement of the visual acuity, our target was 100% of them, but unfortunately only 71% improved the vision, mainly 50% because of the glaucoma and the other 50% with the retina issues. Regarding the appointment per quarter, our target was also 100%, but only 50% of the patient, 57% of the patient have one appointment per quarter because of the 25% were managed outside the Cape clinic. The reason why the patient lost appointment per quarter was because while not managing, also problem with the scheduling, also the COVID lockdown, but 33% because of social reasons. This is the patient that didn't improve the vision after the surgery, and they were not willing to attend appointments. Complications, we still have problem with glaucoma, 40% of the patient, retina 36%, but we highlight this 7%. It's only one patient that had melted, but this patient was managed only to 44 hours of admission, was discharged without any problem, and 18% of the patient didn't have any complication. This is in the Saudi Arabia, in the King Khaled Specialist Hospital, the glaucoma is still a problem, but after you control all the problem of the ocular surface, we reduce a lot the case of removal, evisceration, all the complications of the ocular surface, but there is emergency problems like retina and glaucoma. We were expecting to improve the outcome functional and anatomical. And I also will highlight the glaucoma de novo. Even 50% of this patient, the glaucoma surgery was done at the same time, 23% developed glaucoma de novo. And it's really important, the patient selection, because the glaucoma, the retinal complication are increasing after you control all the ocular surface complication. And as a reminder, the preventable causes of the patient losing appointments is 66%. Only this 33% is the patient that are not willing to attend because they didn't improve the vision. That is, but the other 66% is preventable. Regarding the complication, again, to remind, this is the retina where we're not expecting, that we are recommending to do pars plana vitrectomy in all cases. Thank you for your attention.